Good morning. I'm Dr. Rallo. I'm one of the PEM docs. I apologize for not updating the date on this. I gave a version of this for PEM conference last year. My bad. All right, so pediatric ENT procedures, just kind of an overview, especially in the last year or so, our volumes have gone down. So the things we usually see a couple times a month, we haven't been. So I think we're getting a little out of practice. So, oh, I have no financial disclosures. But these are kind of what we're going to go over. General ENT things you will see fairly often in your career. So start with the easiest. Earwax is a very common complaint, as I'm sure you realized. Both it'll cause decreased hearing, it can cause ear pain if it gets hard and impacted enough. It's a very common complaint of parents that they have about their children, that they see too much earwax and they can't get it all out. Parents commonly make the problem worse by shoving it all back in with a Q-tip, even though we all know you're not supposed to. So there's various things you can do in the ED. Now, granted, none of these are emergent, but nowadays we have plenty of time with our patients, so we can do the nice thing and give an effort to, clean it out as best as we can, with the caveat that ENT clinic does an exceptionally better job at these because they have all the fancy equipment. But first of all, we have the ear curettes. They are around there. We have the white ones with the kind of oval loop on the end. They should be in the top drawer of all the carts. If they are not, ask a nurse and we'll find one for you. But it's good. Position is always important when you're doing this, especially if it's a little kid. Holding the patient still is very important, because if you are trying to clean out an ear and the kid moves and you scratch something, you're all done. The kid's not going to be tolerant of any further cleaning, and now they're bleeding out of the ear. So the kid's freaking out, the parent's freaking out. So control your environment, and because you're just going to have one good chance to do this. So you want to start more at the anterior edge when you're kind of scraping in. You kind of just, visually you can see where you're going for. It helps to have some depth perception. You know how deep not to go. One thing you can do is hold the curette, hold the curette where you don't want to go deeper then, so that when your fingers hit the pinna, you know not to push any farther. And you want to start at the anterior edge and kind of scoop that way, because it's a more acute angle with the TM, so you're less likely to kind of scrape it as you go. I try, if it's rock hard, you're not going to get anywhere with the curette, but if it's the soft, sticky, waxy stuff, you can just kind of one scoop at a time with some irrigation. You can make a dent in it, and then, better off than when they got there. We also usually will send kids home on ceruminolytics, which are just, earwax softeners or dissolvers in general. The contraindication is that you can't irrigate or put anything into a TM that is perforated. But mineral oil works to soften up the wax. Hydrogen peroxide is helpful, just kind of break it up. Hydrogen peroxide is useful more in the ED than sending a patient home and telling the parents to put peroxide in the ear. I wouldn't really recommend that. But in the ED, it is quite useful, having them lay on their side, fill up the ear canal with the peroxide, and let it sit for 10-15 minutes. And then once that is over, get some medium pressure syringe irrigation, and usually it'll be broken up enough that you'll have some clumps and clots come out. And also going home, Colace is very helpful, stool softener in the ears. If they can't find, I was looking at this the other day, and if they can't find the liquid Colace, you can just get Colace pills and break them open, and drip the liquid in there is sufficient enough to do the job. So usually, whether we're successful or not in the ED, we'll send them home with some Colace drops, and they can follow up with their primary or ENT clinic, because you're just making the job easier for whoever they follow up with, so that hopefully they can get all the earwax out. Next thing in the ear is things that are not supposed to be there. If you've been in peds, this happens a lot. Usually in the 2 to 4-year-old range, they're very obsessed with keeping all of their possessions, and what better place to keep things that you want is in your nose or your ear. Positioning is very important. Again, you really are only going to get one good shot at this. If they are, some kids do well if they're seated, like, how you learn how to do the ear exam, if they're seated on the parent's lap with the parent holding their head against their chest. But this is only if you have a parent that is not going to flinch. Usually non-medical parents are much more tentative, and the second the kid starts to squirm or cry, they're going to loosen their grip, and then you're going to scratch something or poke something. So usually I just have them lay down on the bed, whatever ear is up, and then you get some help. The parents can, give the parents the leg or the hands, someone holds the head, and you can, kind of teamwork like that in holding them still. Videos are also helpful. It's tough with the ears, but in any procedure with kids, if you can throw up a YouTube video, it's going to be better than not doing it. Some kids will just be mesmerized and not move and let you do whatever, and the other kids will merely be mildly distracted for a couple seconds.
It's used to have the video first, because I see a lot of people going in and then pulling out the iPad. That's not going to work. You got to get them focused on the iPad, then do it.
Yes, because if they're screaming, throwing up SpongeBob is not going to do much to abate them. If you can see, usually you can see the object pretty well. If it's been in there for a while, sometimes it has wax buildup around it, and it's hard to tell whether it's just wax. Usually you'll be able to see some parts of non-wax sticking out, even if it is in a clump. We have alligator forceps, which is, commonly used. We have multiple sizes of the alligators in the medication room in peds. You just have to ask for it. There are also bayonet forceps to be found. Sometimes you have to go downstairs to Central Supply to grab one, but they are available. Just be careful with the bayonet forceps because they're very thin and sharp and easy to poke holes in things. With older children, you can do a Dermavon trick. I've had it work once out of the maybe 3 or 4 times I've done it. It requires a very still patient and a lot of patience, but you take the wood end of the cotton swab, put a little drop of Dermabond on it, and gently place it and just hold contact with the foreign body. It usually has to be like a smooth surface foreign body where you can make good contact. And then you and the patient will have to sit there for 5 minutes and not move, and then just slowly pull out. And if you're lucky, it will have good adherence to the object, and it'll come out with it. If you don't think that all of those things can happen, I would not even bother with the Dermabond, because if you move, if there's dripping, if the kid turns his head a little, you're going to end up Dermabonding the cotton swab to the inside of the ear canal, and then you'll rip the skin off the ear canal, and everyone's going to be very upset. Irrigation, I think, is very useful, especially if you use a little peroxide or serum analytics beforehand. But you can just use the bigger syringes we have in room 3 in CCT. If you want to be a little fancy, I usually will get a butterfly and take the needle out and put that on the end, so you have a little more focused and aimable exit for the spray. But again, 1 or 2 times, and if it doesn't work, then you've done all you can. For the most part, as long as the object isn't a button battery or something organic, there is no emergency to take it out. They can go to ENT clinic the next day. They can go to ENT clinic the next week. Pieces of paper or plastic or cotton in the ear are not going to do any long-term damage. The organic issues, it's just because of the moisture, they can swell up over time and be much harder and wedge themselves in. Our ENT at Kings County is usually very responsive to quick follow-ups. They might get a little cranky for a non-emergent foreign body in the ear if you call them to the ER. But if you call them, tell them what's going on, they can usually say, oh, have them come in at 1 p.m. tomorrow in clinic and we'll take care of them.
I tried it to like suction, like you get like a 14-minute gauge in the middle and you can have it there and you can make that suction, cut it a little bit, if it's a little too long, and then you go there and show you work.
Yeah, I've started using the yank hour more and more in both nose and ear foreign bodies, especially, you know, with irrigation. Irrigate it and jostle it all up and just go back and forth with the yank hour is another good idea. And the suction is not going to be too strong to suck your TM out and mess with your ossicles for sure. Acetone nail polish remover is very good for kind of starting to dissolve the things that are stuck there. Styrofoam, super glue, Gorilla Glue, as is in the news recently. It takes a very long time for acetone to dissolve it, but it will eventually do the trick. Coach?
I was just going to say, piggyback on what you said before, every time I go into the patient's room with a foreign body, without even looking at it, I tell them, listen, you're going to give the maximum 2 attempts. Sometimes it causes more harm than good. Sometimes it can like scrape the ear canal, you can get a lot of bleeding, so like parents get really traumatized by it. And then I usually tell them like, we'll take a look at it, but if it's cheaper or something like that, like you said, it's not going to hurt the patient, it's not going to kill the patient, and you can always follow up with the stuff at the end. But always just walk in without even seeing what's in the ear, just talk to them about it. Because sometimes parents get really frustrated that we can't take it out, and then the ear starts bleeding, and it's a full ordeal.
Okay, and that was comment just, it's a good idea to prep the family before you even start, like Kosha said, just to give them a heads up, because sometimes they'll get transferred to the ER for this, you know, by an urgent care or another hospital with the expectation that the ENT attending is going to meet them in the ER. So, you know, go in, this is what we do, this is why it's not emergent, we're going to try our best, this is our backup plan. Because after all the screaming and everything, they're a little less receptive to like, all right, see you later, we didn't do anything. And then another trick if you are stuck is if you could take a needle and bend it and blunt the tip at a 90-degree angle to create an L. Sometimes that is thin enough and you can get behind the object and pull it forward. Cauliflower ears. Thankfully, in New York City, high school wrestling is not a big thing, but doing fellowship in Missouri, you see a lot of this. Usually it is wrestling. It can be any sport where you have blunt trauma or some sort of rubbing pressure to the ear. It will blow up within, you know, an hour or so from the event. And the most important thing is it needs to be treated. Because if you don't take care of this, the blood will clot, it will destroy the cartilage in the ear, and you'll be stuck with permanent disfigurement. All you have to do is Google college wrestlers, and their ears are just ridiculous. If you look at college wrestling coaches and their pictures, their ears are barely hanging onto their head. Clinical diagnosis, usually they're quite fluctuant unless they have delayed presentation and it started to clot. It is necessary to rule out middle ear injury, so you have to look in the TM. If there's so much swelling that you can't visualize the TM, usually that's an indication for ENT to see the patient to make sure there's no damage within the ear. But these should be drained as soon as possible. There's 2 methods. There's a needle drainage and then a full incision and drainage, depending on the size and quality of the hematoma, which I'll go into in the next couple slides. And it's not a pleasant procedure, so analgesia is important. You can either do local anesthesia with some topical if you're going to do a needle drainage. Usually if you're going to do a full IND, you do the auricular hematoma block. So for needle drainages, these are best for small hematomas that are less than 48 hours old. Usually you can, you know, milk, it's just one area. You can see, you know, in this picture, it's just the superior portion kind of right up here, but the rest of the pinna and the auricle are kind of intact and not swollen. So clean the area. You want to just milk all the fluctuants to kind of the most superior part to kind of get the most for your money. And then just insert the needle, drain it, and then you can kind of, you don't want to break up loculations with the needle, but just kind of gently move it around and suck up as much as you can while milking, you know, whatever fluctuants you have to the spot where the drainage is. And then once you're done and you're fully expressed, you have to hold pressure and put a pressure dressing. It's a very overlooked part of the auricular hematoma drainage, is that if you don't have pressure holding the ear flat, it is just going to reaccumulate and you're going to be back where you started. For larger and older hematomas, you usually will have to do a larger incision to get, because by then there's some clots in or there's loculations and you have to go around to different parts, and it's something that you can't just pull out with a simple needle. These are more useful with the nerve block, which is on the next slide. Usually, you take an 11 blade and your incision should be with the curve of the ear. You don't want to make just a straight diagonal incision, but think cosmetically, think of, plastic surgery rotation that you did for a couple of weeks. You want to go with the skin lines. In the ear, it's useful because it's showing you the curve, right? You want to just follow the curve of the ear with your incision when you make it. And then evacuate what you can, suction, use the blunt forceps to break up the loculations, irrigate it with some normal saline afterwards, and then you close it with a mattress suture. They recommend not closing it completely tightly and leaving a little opening for some drainage to come out further. And then you want them to follow up fairly frequently. They don't have to go to ENT clinic in that 2 days, but they should see someone every day or two until they officially see the ENT doctor, just to make sure it's not reaccumulating and that, everything looks well. And then they do recommend prophylaxis with augmentin for this. So these are just some pictures. You guys should know about the hematoma block. It is, these nerve blocks tend to be a little overwhelming when you first think about them, but they are easier than they look. This is fairly, the nerve, it has a complex nerve innervation to the ear. So just make sure you have to cover the entire perimeter of the ear with some lidocaine. And then there's just an example of the suture with leaving a little open to drainage. And then the pressure dressing is something that we kind of gloss over sometimes, but it is quite important. It is helpful to use this kind of base of a dressing around the ear. It doesn't have to be fancy. Cut a hole in a 4x4 and just kind of, if you've ever seen someone with the G-tube and you kind of cut the slit in the 4x4 to put under the G-tube to protect the button from the skin, this is kind of your same theory. You want some cushioning against the skin so that you don't have just pressure and erosion on the side of the head. And then you want to pack the inside of the ear with usually a Xeroform Vaseline dressing. Will hold the shape better, because this is what's going to maintain the shape of the ear to prevent any post-IND collapse and disfigurement. So you want to literally pack the Xeroform up into the curve of the ear, because that is what's going to hold the shape in place. And then you kind of throw another couple 4x4s on top of the Xeroform, wrap it around the head.
Sometimes they'll even sew in on the dressing.
Mm-hmm. Yeah.
Sometimes they'll actually sew on the dressing for the ear.
Yeah, like a chest tube, throw a couple stitches in there. All right. Nosebleeds, very, very common in peds and very, very frightening for parents. Parents will often come in for single isolated nosebleeds, even though they've already resolved. Just in the last week, I've had 3 patients come in for nosebleeds that happened the prior day, but they were just concerned about it, that they woke up the next day and wanted to get checked out because their child was bleeding. It's fairly common. There's not a huge amount of data on the incidence of nosebleeds in pediatrics, just because of how common it is. It's second knowledge. But one study a very long time ago found that almost 1/3 of children under 5 and more than half of school-age children have had one nosebleed in their life. It is rare in children under 2 years old. So if there's not a history of he fell and hit his nose, spontaneous nosebleed should raise a little red flag to you in those younger children, should prompt some sort of deeper evaluation. Is there a foreign body that the kid shoved up there? Is there an unknown coagulation issue? Is this a non-accidental trauma patient? All right. 1-year-olds are really not going to injure themselves, especially if there's no story to give themselves a nosebleed. It's not, a classic thing, but it's something that if you see a 8-month-old who comes in with a nosebleed, should take a little more time with your history and figure out, does the story of what happened make sense to this kid? It's just a highly vascularized area, so any minor insult, dry air, sniffing too hard, blowing your nose too hard, picking your nose, which despite the child and parent denying, happens all the time. I mean, they will deny the kids picking their nose while the kid's knuckle deep sitting right next to them. I found the kids are much more ready to, you pick your nose and they'll be like, yeah, I do. Double fisting up their nose. It's important to locate the source. The vast majority of these are anterior nosebleeds. You can directly visualize where the bleeding is coming from or where the clots are, but be sure you're not missing a posterior location for the bleed, because those can be more serious and have greater morbidity. And if you can't find where it's bleeding from, or you can't see where it was bleeding from, you should continue to look to make sure that you're not missing a posterior source for the bleed. And if you need ENT to come and throw a scope in there, that is what you should do. I don't want you to read this, but this is just the list of lots of different things can cause nosebleeds. But most likely it is local trauma or dry air or irritation to the area. So direct compression, right? What do we tell all our parents? Everyone thinks you have to pinch or lean back, and you lean back and all the blood goes down to your stomach, and then they're in the ER 3 hours later because they just vomited a bunch of blood and they're terrified, all right? Sit forward, lean forward so that if you're not pinching enough, it's coming out onto the floor, and pinch. Set the timer, all right? 10, 15 minutes is forever when you're just sitting there pinching your nose. And people usually give up about like the 4-minute mark, and then it's still bleeding, and then they're upset as to why I'm bleeding out. If more than 10 minutes of compression does not stop the bleeding, then you can kind of go into your tools. Topical vasoconstriction, we have Afrin. It's not in the Pyxis, but it is readily available from the pharmacy. And then phenylephrine is another alternative for the older kids, but it is relatively contraindicated in children because it's just the amount of it can be absorbed and have more systemic effects. But Afrin is great. We don't recommend Afrin for long-term use because you can get rebound eventually once you stop using it. But for short-term use, it is great for this. ENT usually squirts Afrin in the nose of pretty much every patient they see before they go in and do something. It just makes their life easier. Various cautery devices, usually the silver nitrate sticks that we use for umbilical granulomas will work, or electrocautery if you can find one or are fancy. But this has to be a very anterior location that you can easily get without hitting any other things, because either of those, if you just so much as touch something, it's going to burn off. So you don't want to go digging in there. But if there's something very anterior that you can obviously see and didn't stop with pressure, just a little dab should take the trick. And then nasal packing, or usually if you have a more serious bleed that takes a while to stop, or you need cautery for it, you should pack. And nasal packing is a very in-depth process. You can see how much you actually have to fill up the entire area of the nose. We do have, I don't know the brands of them, but I know in Peds Cart in room 7, I assume in various places in the adult ER, we have nasal sponges, absorbent, expanding Rhino Rockets, various nasal sponges that you can use. But the traditional is just straight Vaseline gauze with bayonet forceps. And you just insert the gauze along the floor of the nasal cavity, and it'll eventually fill itself up. The way you confirm the hemostasis with the packing is you open their mouth and you just watch and see if any blood drips down their throat, because it's obviously, you can still be bleeding and it's not going to come out the front because the packing and the Vaseline will absorb and block it. But, you can even have them just stand there, lean back a little bit for a couple minutes. and make sure they're not bleeding down the back of their throat, just avoiding all the packing you just put in. And then the packing can be left in for half a week before follow-up. We recommend antibiotic prophylaxis because you always have the risk of toxic shock syndrome or blood-soaked gauze left in a moist, warm place is usually not a recipe for success. If you have a posterior bleed, I would recommend involving ENT early. Afrin, and then also the aerosolized lidocaine can be helpful for these to kind of get in there and try to find the source and treat it. There's various, this is going to be mostly ENT. I've never done one of these without them, but just to know, it's a pretty fancy balloon catheter treatment where you can use a Foley as well. The ENT has these double balloons that make your life easier, but you basically snake a Foley through their nose down into the oropharynx and grab it and blow up the balloon and then pull it back. And you've effectively blocked the nasopharynx from going down into the oropharynx. And then you can do the same. If you have a double bubble, you do a second one at the anterior and you kind of block it in. If you don't, you just have the Foley, you do the posterior bubble, and then you pack the nose like you would with an anterior bleed. But again, I would have ENT do this with you. Septal hematoma, fairly uncommon. It's one of those things you always have to rule out. Any kid that comes in with facial injury, nosebleed, it's one of those things, it's one of those can't miss things, but you don't see it very often. But always something to look for, because again, like with an auricular hematoma, if you miss it, the blood is going to clot, it's going to destroy the cartilage in the nose, and you are going to have a hole in the middle of the face for the rest of your life, which is a very litigious event if it does happen, understandably so. So this is an obvious picture up top, but any swelling, you shouldn't have some midline mass blocking your view of the nose when you look in the nares. Especially they can be flesh colored, but usually they're more of a darker red, purple into the blue. And another thing that can help you, if you're unsure whether it's a mild septal hematoma or just inflamed nasal airways, is if you spray it with Afrin, an inflamed airway will shrink a little bit. A septal hematoma will not change in size. So in order to do this, you lay the patient down. You can use some topical lidocaine, like some aerosolized lidocaine to help. And then just an 11 blade incision and treat it like any other clotted hematoma, little blunt dissection, take whatever clots you have out. The recommendation, I haven't done one of these in a very long time, but the recommendation the last time I did it was once you are done, you once again do the full anterior nasal packing and antibiotics, and then you follow up with ENT in kind of the 3 to 5 day range. Foreign bodies in the nose, usually more common than the ear from what I've found. It's most commonly in the right nair because most children are right-handed and you do what you know on that side. Some kids just love putting things in their nose. I haven't seen them in a while, but we had this cute little 4-year-old boy that put paper in his nose every single day. I personally saw him 3 times in 2 weeks at one point, and his mom just kept coming in. She's like, I don't know what to do. So I know I haven't seen him since COVID, so hopefully he's just aged out of it. But it happens a lot. Some kids will proudly go tell their parents that they just shoved a Barbie head up their nose, and some kids will have it there for a while, and then their parents will, he's snotting, or they happen to see something blue when they looked a week later, or, you can have, if it's in there long enough, depending on the object, you can get, purulent drainage eventually, or the parent will remark on, it just smells bad. There's just some foul smell from his mouth or his nose that didn't used to be there. It can be a clue. The 2 most common locations are up and back. You know, they'll either put it up and it'll be kind of wedged up right in front of your middle turbinate, like the blue thing in this picture, or they just shove it straight back and it'll be kind of along the floor of the nasal cavity. But most of these are asymptomatic, even if they've been there for a while. Like plastic, you know, a piece of plastic or a piece of metal usually isn't going to become some sort of mucopurulent thing. It's just going to stick up there and stay there forever. Most of these can be visualized. You know, we have the nasal speculums. Not everyone knows that we have those in our med room. They are very, very helpful because the skin around the nair is very elastic and expands more than you think. So it is very useful. Even if you can see it, just make your life easier, make the opening to the nose a little bigger. The nasal speculums do help. They're not painful. Most of these objects are non-metallic. If there's a strong history of some sort of metallic foreign body that's been put in the ear or nose, I have done skull x-rays before just to kind of rule out anything metal, but you just have to know the majority of things are not metal, so a negative x-ray just tells you that there's nothing metal in there. There could be a million other non-metal things in there. I would certainly not recommend routine x-raying of skulls. I've only done it when the parents like, no, I know they put, you know, a metal thing in their ear and you can't see it. Like with the ears, anything organic or porous should be removed sooner rather than later just because of the increased infection risk. There's, I mean, styrofoam, pieces of sponges, that's just right medium for lots of bugs to get infected. And then magnets and button batteries should be removed emergency in the ED. Just because, especially, God forbid, you have two magnets, one on either side, you're going to erode right through your septum. The button batteries, just a reminder that why button batteries are so bad is that your regular AAA batteries, the anode and the cathode are on the opposite ends. Button batteries, I forget which one's which, but one of them is in the middle of the surface and the other one is around the outside. So that one flat surface will have both the positive and the negative, which is why you just get constant voltage going along that surface. It's not the front and the back. It's positive and negative are both on the same surface of the button battery. Yes, Rosie.
We have a patient where mom had suspected that the patient had put something up her nose. We couldn't visualize anything, but Dr. Chow had said sometimes getting ENT to stick them might be worthwhile because it could be so posterior that it's past the anterior turbinate. Are there specific things that make you more inclined to consult ENT to do like a proper scope if you can't see anything? Or is it just really like if you don't see anything, if you're like discharged happens to happen, then you should come back versus having ENT come evaluate?
Great question. So the question was, if you can't see anything, should you be reassured or had ENT come in to rule it out? I don't think there's a straight answer. I think it's really case dependent on the history, like how confident. If it's, you know, the kid's rubbing her nose a lot and she snorted once, then, you know, it's a little more reassuring than she told me she put something in her nose and I can't see it, or the sibling saw it. So it's depending on the age and the maturity of the kid, what your story is, what you see on exam. If there's some sort of, you look in, there's a lot of abrasions and irritation and inflammation versus a completely clean, untouched, you know, nasopharynx that you can see. I have done both. I've had, you know, I can't see anything. There's probably nothing there. Follow up in ENT in a couple days, or I can't see anything, but there might be something there, and ENT will come scope these.
Nasal drainage from only one side of the nose is also kind of a telling sign, especially if it's purulent or blunted. That's how I found in both of somebody's nose. Because the grandparents came in and they said, everybody knows there's only one's on one side. And we've been watching it, and only one's on one side. And so I actually got an x-ray because I couldn't see anything before I put water on the ENT, and it was a bolt so high up that it was practically in the brain.
Yeah, Dr. Khan just mentioned another great point is that unilateral nasal drainage in children should always raise concern for this. URIs, even bacterial sinusitis, will not usually give you unilateral drainage. So that can be another red flag that there is a foreign body or something going on in there if there's only drainage out of one side of the nair. So the mother's kiss is very successful. Usually if it's not successful, it's not done properly. But usually, the parent is willing to do this, especially if you explain to them, it's like, well, if this doesn't work, this is what we have to do. They're a little more, but you basically occlude the uninvolved nostril and have the parent give just positive pressure breaths mouth to mouth. And more often than not, as they're doing it, they'll get hit in the side of the face with a boogered laden object that has come flying out of the nose. Kosha.
So I have a version of mother's kiss that's not as disgusting. No one should be putting their mouth on anybody. Okay, so the kids are always naughty. So what you can do, take a gain tower, attach it to the suction tubing, but do the tubing to oxygen, not the suction. Set it up to like 10, 15 liters. Stick the yank tower in the opposite nose and close the mouth. So it's like a 100% effective.
That's-
It works every single time.
That's a great
Also
circuit.
using BPM
So,
to produce pressure and-
yes, yeah, because the other thing, if there isn't a parent there, or if you're unwilling to make out with the child, you can use the pediatric bag mask and put it over the mouth and not the nose and give positive pressure that way. The other thing that Kosha said that she has tried successfully is having a yank hour to blow by oxygen all the way up instead of suction, and putting it in the unaffected nair, blocking the mouth, and then the circuit of air will theoretically go in the nair, out behind the object, and blow it out the affected nair. Yes.
What are your worries in aspiration?
So your worries of aspiration is that you don't want to ever push an object back. It's very tempting if you have an object that's very posterior to just shove it, and then they can either spit it out or swallow it. And that is when aspiration is. But with the positive pressure ventilation, it's much lower risk because the air is coming in it's actually more protective. It's coming in, the object would have to go against the positive pressure airflow in order to go into the oropharynx with the aspiration potential. But I would urge you, even though, because I've been very tempted before to just poke it and, because it's probably going to be fine, but do not do that. So yeah, the studies have been done, found that in, 3/4 of cases, mother's kiss does work if done correctly. It is easier done in more anterior foreign bodies and smaller, smoother objects because they're mostly completely obstructing. So the positive pressure will get through them and not kind of go around the edges of an irregularly shaped object. You can pre-treat with, Afrin or lidocaine or things like this. I usually don't. But if it is, especially if they've come in with previous attempts and there's a lot of swelling, Afrin can be very helpful. Restraint and a light source. We have fancy overhead lights in every room of the emergency department, and none of you ever use them for anything. Lacerations, INDs, every time I come into the room, you guys are bent over with the bed this high and no lights on. It doesn't make any sense. All of our beds go up into the air, and there's very, very good lights above every single bed. I implore you to use them. Restraint is also very important with the nose, because like the ear, you're not going to get many chances, especially if you mess up the first one. So holding is very important. You need a dedicated medical person on the head. Do not let the parent hold the head. The parent can hold the legs or the torso or the hands. Have someone that works here hold the head. You are not going to crush their skull by holding their head still. This child shouldn't move. You are stronger than a 3-year-old. And then, they may require sedation. I can't say I've ever sedated one unless there was some sort of like button battery metallic thing, and I'm doing it with ENT because it's a more emergent thing, but you shouldn't. And then there's everyone has their favorite tools. But we have alligator forceps, we have bayonet forceps, we have curettes, we have loops. What we do not have are these fancy cast extractors, which are amazing, but they cost more than $0. But it's basically like a mini Foley on a syringe. It's these little catheters on the end of I think it's a 3cc syringe. And all you do is snake the syringe past the object and blow up the balloon and pull back. The same thing can be done with a pediatric Foley catheter. But you know, especially if you have an object that you see an opening where you'd be able to pass something, but you otherwise can't get it out, or if it's wedged in there, if you're able to get a catheter, either a CATS or a Foley, past the object and blow up the balloon, you're usually successful in pulling it back out. But yeah, I mean, various tools, everyone has their favorite kind of mechanism that they use. So compressible objects or objects with rough surfaces can usually be gripped with forceps. Unfortunately, beads and balls and marbles, you're not going to be able to get a grip with, you know, alligator forceps or even the bayonet forceps on these. That's where you want to use some sort of loop or a scooping device or these right angle curettes. Like I said, with the ear, you can take kind of a bigger needle and use the needle drivers to kind of bend it at a 90-degree angle to get around it and pull it out. And then theoretically, you can use the Dermavon trick here, but I would caution against it because it's a very rare set of situations where it's going to work out well. You know, usually if they're old enough to hold still for Dermavon, they're old enough to know not to shove things in their nose. Any questions on foreign body removals, comments, tips?
But going back to the epistaxis in adults, one of the things I found useful was aspirin and Nielsen phenylephrine is always ready available. You can take a little bit of epi or epi with lidocaine, put it on the gauze, and then put it where you're seeing the bleeding, and that will, in a lot of cases, decrease the bleeding. And then you can also then cauterize easier with silver nitrate.
Mm-hmm. Yeah, Dr. Gersheimer just said, you know, if in epistaxis, if you can see the source of the bleeding, just simple gauze soaked with epi and lidocaine with direct compression can help.
When you're doing prophylaxis, or when you're putting nasal packing in or doing the septal hematoma, are you giving them just like a single dose of Ptas, or are you sending them home on a couple of days while the packing is still in place?
You send them home. They should be on antibiotics for the duration that the packing's in place. So you send them home until I give them the prescription that gets them to the ENT follow-up that you've scheduled.
We did have a conversation a bunch of months ago whether or not these patients really need antibiotics. I mean, well, no, always is. You got to give antibiotics when you pack a nose, but there's really no data to support that.
Yeah, great. It would be a great resident or fellows project.
When you're suctioning for a foreign body in the ear, so I didn't get it. Could you injure it with maximum suction or not?
So theoretically, the question was, if you suction to the ear, can you pull the TM out? Theoretically, if the suction's high enough, I have used maximum Yankauer suction on ears multiple times, and I've never taken an ossicle out, so it's probably fine. I don't know of any data or rules on it, but I don't think that our maximum suction is powerful enough to do any damage. And in my N of, you know, double digits, it's never happened.
Yankauer is longer, so it's going to probably be a suction field on the outside of the ear with mouth, versus you can use a smaller tip, so you can circle a smaller tip going in. Then you can cause injury, not only by direct pressure from your side and the outside, and
Yeah, Nay?
Not sure if I just like didn't hear this part, but for the ears too, rather than being water irrigation, you can get almost any form body out if you use a big enough syringe to give enough pressure for water irrigation. Even if it's paper, I think right? We did one together because the paper will expand still and then pop out. So it's something to consider if you try other mechanisms, you can't get it out, or if you even want to do it the first attempt, if you just get a big enough syringe that goes with 25 cc's and push, you'll get it out.
Yeah, Nay mentioned, I did glaze over it, but irrigation with saline or water is also useful in ear foreign bodies. Yeah, the amount of pressure is not going to damage the TM. I would urge you to use room temperature or warm water, because cold water is unpleasant and can give you nystagmus and kind of, temporary neuro symptoms and be very uncomfortable. I had a bug fly into my ear once and was alive for 4 hours in the waiting room of the ER, and it took a 30-second irrigation for it to come out 4 hours later. It died in my ear like 5 minutes before I got called into the ER. So it was scratching.
If that happens, what you can do, put a little lidocaine in there, it'll paralyze them, kill them.
Yeah.
Paralyze them, and you can get them out easily.
Yes. Often you will see, this was a moth, thankfully, but we see roaches not uncommonly crawl into ears while people are sleeping. I've had 4 of them in the last couple years, bugs crawling into ears. You can kill them with lidocaine. You can kill them with mineral oil. You can kill them with vodka or other high-proof liquors. And then depending on how big it is, usually you recommend to kill them because the bugs are smart and they will grab on and prevent getting dragged out. So if they're not dead, they can't claw into your ear canal. But irrigation can help. You can also, forceps can help, but I found when you do use forceps, you will eventually take the bug out in pieces. So now that you have multiple pieces of bugs and bug guts all strewn about, so I would recommend irrigation first with the hope of getting the bug out one piece. But it is very useful to kill the bug first. You can even use some viscous lidocaine, and that will kill the bug and provide topical anesthesia to the ear canal. But it'll make your job easier and it will make it much more comfortable for the patient if the bug isn't scratching on its way out. And then I just had a couple slides on PTAs. It's complications of pharyngeal tonsillitis. You get a collection of pus located between the tonsil and the pharyngeal muscles, where that's the space for the fluid to expand. This does require either needle drainage or incision drainage to get the pus to come out. Usually you'll have a severe sore throat. Clinically will be worse than the average pharyngitis patient that you see. Usually they will tell you that it is much worse on one side. You commonly will see uvular deviation away from the affected side. They commonly, but not always, will have the hot potato muffled voice. Even if they're not good at describing, you can simply, is her voice different at all? Even if they can't describe the muffledness, but any voice changes. Commonly, the pain will be bad enough that they will not be tolerating their secretions. And they have trismus, which is just the inability to fully open the mouth and extend the neck, which can hamper your exam, so you can't see as much because they can't open their mouth fully. But usually you'll see a fullness. I think people sometimes look at the tonsil, but it is not a tonsillar abscess. It is a peritonsillar abscess. So the abscess is usually superolateral to the tonsil itself. And you can commonly, if you poke it with, a Q-tip or a gauze, it will have some fluctuance to that swelling of the area. And then just anatomically cross-section goes to show all the very important things that are behind the tonsillar pillar that you do not want to bother with a needle or a scalpel. The clinical diagnosis until you get the pus out. So if you have, there's not, even if there's a little swelling, you don't always need to go straight to the IND. There's kind of a continuum of symptoms: cellulitis, suspected abscess, known abscess, especially if the patient is tolerating secretions, doesn't have any airway concerns, but there is some fullness in the tonsil and they've had, an extended course of symptoms. You can trial antibiotics. They recommend admit for IV antibiotics with the suspicion of a PTA. There can be acute worsening at any time, but it is not a radical idea to admit them for 24 hours of antibiotics and then see how it goes. ENT, if you consult them, will sometimes give you this recommendation: let's just admit them on antibiotics, and if it's worse tomorrow, we can go in and drain it. But then again, if there's severe symptoms, if it's a very impressive exam, you can just go ahead and do a drainage of it. Usually, I mean, thankfully, these more happens in the teenagers and the older kids, so they're a bit more cooperative with the drainage. Success rates for both needle and a full IND are similar, so I haven't found anything that says one is better than the other. I think oftentimes ENT will just needle it. So the needle aspiration, you get a large size needle with a big syringe. Patient should be sitting upright and you should aim for the most fluctuant spot. You want to start higher at the upper pole because that's where the more common collection, that's where your juiciest spot is. And if you don't get anything, then you kind of move your way down. If you get a large collection from the upper pole, you can stop there. Now, you don't, like I showed you before, what happens if you put the needle in too deep? You're gonna hit their artery, dissection, strokes, all bad things, all right? So you have to be very careful not to put the needle in too deep. There's various methods to do this. Everyone has their own, but usually some sort of marker on the needle. You know, they say insert the needle no more than 5 millimeters into the skin. So count out your 5 millimeters. You can put, you know, get some surgical markers. You can put a little piece of tape, whatever. The other thing is the safety cap. You can cut the needle safety cap where you are and then put the cap on so that once, you know, you only have so much needle and the rest of it has the plastic cap on it. Whatever your method is, something that is a visual reminder, I do not want to put the needle in deeper than whatever my lock is, because you certainly don't want to go out the back wall of the area. And then if you choose to do a full incision and drainage, you know, you need to have an assistant there with the Yankauer. And then, you know, I've done it once. I usually do the needles if I do them. Here, I commonly just get ENT to do them. But it's not that big of a procedure. You aim for the most fluctuant spot at the upper pole, and you just make a small, I mean, less than 1 cm incision. And then, as tolerated, use a blunt hemostat, break up some loculations, throw some suction in there. You don't need to close it. Just, it will heal on its own. You don't need to stitch these after you incise them. Any questions on that? Yes.
I wouldn't use a tongue depressor. I would use a laryngoscope because you have the light built in. So it's like tongue depressor plus light. Very, very good, helpful instead of sitting there with the light and the tongue depressor. It works really well.
Great suggestion. Instead of a tongue depressor and the handheld light, use a laryngoscope to put, you know, keep the tongue on the floor of the mouth, and then you already have your light source built into it.
And the other thing is, if you're really not sure if it's cellulitis or abscess, you can do ultrasound in bigger kids. I wouldn't stick it in, and then the cavitary ultrasound, you know, cover it obviously. But you can do an endocavitary ultrasound, the same one as the transvaginal probe, and to see if there's a fluid collection there. It's not something I do very often, but it's something you can really think about if you really trust going back and forth. You're not sure if there's fluid there, you don't want to stick a needle in.
Bedside ultrasound useful for ruling out abscess.
And I've seen Dave Russ do it even from the outside.
I have seen that before. Yeah,
and
like
it really
percutaneous
works well.
ultrasound
This guy
to look at it.
was looking for the fluid, and he came up from up here, and then the action, I was very impressed. And then the other thing is almost always between a peritonsil cellulitis and the abscess, I have found if the uvula is deviated, it usually has an abscess in it. And that's a good clinical sign for me, at least.
Correct, for sure. Yeah, usually, you know, even a very, very bad cellulitis will not deviate the uvula. True. That's all I got. Any other questions at all? We are almost successfully daytime potty trained. You've had 3 days without a pee puddle on my floor.
Don't worry, it'll still happen.
I know, yes. Yes.
Sorry to keep going back to the ear. I'm wondering when we actually do competency, and I remember having a case that we do a put in here, the school teacher put feed in it, and we told mom like 2 days later. We had a ton of inflammation in the ear, so we couldn't see it. That
that's why we contacted ENT, and the guy was like, I don't have the instruments here to do anything, you have to. But what should our management have been at that point? And do we give steroids, what do we?
I just Motrin as needed. Yeah, there's no indication for like, otitis externa prophylaxis treatment, because the majority of these objects are, pretty aseptic, the most difficult objects to get are your smooth round plastic ones. So, usually plastic beads, hair beads like that. Again, if it's not one of those, porous, spongy, button battery, dangerous things that need to be emergently treated, it can stay in there for weeks. Commonly, they have been in there for weeks. There's plenty of beads in ears that we've incidentally found months later when they come in for a cold and you're looking in the ears. So yeah, so if it's not one of those, small number of emergent and needed to be emergently removed objects, it can stay in there forever. If they can't get ENT for 2 weeks, then it can stay in there for 2 weeks. It's not going to permanently damage their hearing, in that short term.
So the other thing that we have to do with is local hospitals, patient, because they attempted to take somebody out of the ear, and if they go to Kings County, they get ENT, they'll take it out there in the emergency room. The parents come with an expectation of this thing is coming out the minute they walk in the door. The unfortunate thing is, one, likely doesn't need to come out immediately, and two, if they had courtesy call us first, we would try to arrange this ENT appointment. So you have to be ready for that parent who wants that out the minute they walk in. And you can still tell them that this is not emergent, this is an LMD that I cannot get you without injuring your child. I can't see it because I'm trying too hard, maybe not pick up. So this is all that's in there. So you can refer them still from ICD to ENT, but you just have to do it knowing that you're going to need like a little bit of a, background in the field. Because they're going to come in probably next because the second hospital visit in the
Yeah, Dr. Thomas just saying that, everyone in the community knows that we have ENT. So Coney, Mount Sinai, Brooklyn, Kingsbrook, all these places, they'll set the parent up, kind of to get them out of the door with a smile on their face. We'll tell them, oh, you'll get to Kings County, they'll take it out, no problem. So it's very hard dealing with those expectations, especially if they show up at 2 o'clock in the morning on a Saturday. This is not something you're going to call ENT for to take it out. But like I said before, they're very welcoming to prompt clinic follow-up. I even had one the other day. It was 1:30 and we called them to get an appointment later in the week, and they said, oh, just send her over right now. So we discharged her. She walked next door to the E-building. They took it out in like 10 minutes. But yes, and if you ever get a transfer call for a foreign body removal, that's your opportunity to, like Amber said, not only, oh, we don't need to do that, but let me help you make an ENT follow-up for this patient. And, you can kind of bridge the gap there so that, you don't have angry patients or, a completely unnecessary transfer. Because you think about these transfers, they've been in that hospital for God knows how long. From the start of the transfer to them arriving to your hospital is hours. So by the time they've gotten to you, they've already been at the ER for, sometimes 5, 6, 7 hours. And then from their point of view, you're going to tell them, oh, it's fine, you didn't need to be here in the first place. So it's just a very frustrating situation that you just have to deal with gently.
Sorry, I have one last ear story, which is I had a kid who said he had put a cotton like a Q-tip in and then taken out, and the white part didn't come back out. And then I jet irrigated it, and it was a BB pellet. And he's like, I haven't played with a BB gun for 2 years. So I'm just saying, like, it can really be in there for a long time, and kids can even be asymptomatic, but yeah, it's fine. That's what the point of the story was.
Okay. All right, thank you guys.